Good morning. I'm Mike Tuttle from Memorial Sloan Kettering Cancer Center. Welcome you to this week's tumor board for our International Thyroid Tumor Board, sponsored by the Think Foundation. Next slide. We have a wonderful group of panelists with us today. Today, the cases all come from Gustave Roussy in Paris, and we'll introduce Dr. Hartl in just a minute. We have one center presenting 3 challenging cases and a group of panelists that is my pleasure to pick on. And
that important. It's going to behave like a pulley.
We're thinking about these cases. To start with, let's start with just having the panelists introduce themselves, probably in order. Dr. Ghossein, a couple sentences about you.
Hi, I'm Ronald Ghossein. I'm the director of head and neck pathology at Memorial Sloan Kettering Cancer Center, working with Mike Tuttle. That's a title.
You poor thing. He apologized for that. Carrie?
Hi, good morning, everyone. My name is Carrie Lubitz. I'm the section chief of endocrine surgery at Massachusetts General Hospital. Good morning. Thanks for having me.
Bryan?
Yeah, hi, thanks, Mike. My name is Bryan McIver. I'm an endocrine oncologist at Moffitt Cancer Center in Tampa, Florida, where I also am the deputy physician-in-chief for the cancer center.
Fantastic. David?
Hi, my name is David Pattison. I'm a nuclear medicine specialist at the Royal Brisbane and Women's Hospital in Brisbane, Australia, and I'm the deputy director of the department.
And fairly time sensitive and time conscious, so we keep an Australian clock behind us. That's the official time clock of the morning. Thank you, David. Fantastic. Dr. Wirth.
Good morning, everyone. I'm Lori Wirth. I'm a medical oncologist at Mass General in Boston, and I take care of patients with head and neck cancers, including advanced thyroid cancer.
All righty. Next slide. Dr. Hartl, you want to introduce yourself, and then we'll get started on the cases.
Yeah, hi. Dana Hartl. I'm a head and neck surgeon specialized in thyroid cancer, head of the thyroid surgery unit at Gustave Roussy Cancer Center, just outside of Paris in France. And so I'll start up. I just really want to thank the Think Foundation for organizing these really incredible meetings, and thank all of the panelists for being here today. I want to thank Mike for moderating, and so Mike is just going to jump in as we go along. And any of the typos that you will see are entirely my fault. I apologize. We're going to start with a case of locally invasive cancer. You could go on. It's a patient, it was a 70-year-old male who came to the clinic after having felt on himself in his own neck this big mass that seemed to be growing. Otherwise, he was in great shape. He had some vascular issues with cholesterol. He had had a transient ischemic attack a few years ago. He was on low-dose aspirin, but other than that, he was in good shape, and he wasn't symptomatic except for this neck mass. He had no dysphonia or dysphagia. And the larynx was more normal. So when we have an older patient like that, of course, we start thinking about anaplastic thyroid cancer all of a sudden. So we got him very quickly a CT scan, and we very quickly generally do a PET scanner, FDG PET, for these patients. And he had a thyroid tumor also with mediastinal nodes and lung metastases. Next slide.
Let me pause for a second. Stay there for me a minute. Dr. Wirth, everybody talks about rapid progression and anaplastic. I mean, what does that really look like? When it's a real anaplastic, what is rapid? What do you see when people come see you?
So usually patients are able to report a pretty rapid, noticeable growth in the mass in their neck over just a few weeks. Often too, I think that the tumors tend to cause pain and be tender to palpation. When we see that, I always really worry, because generally thyroid cancers don't cause pain. And then associated symptoms are also very common: hoarseness, dysphagia, and shortness of breath in particular.
Yeah, Bryan, anaplastic is pretty uncommon, but we get called a lot about rapid progression that's not anaplastic. So 70-year-old guy outside of Paris, rapid progression, what are you sort of thinking about now in terms of possibilities, likely things it's going to be? Sort of bring us sort of where you're thinking.
So for sure, anaplastic needs to be on the differential here with a rapid progressive neck mass. Of course, rapid is only in the eye of the beholder. So The question is this weeks, which you would expect with an anaplastic, or months, which might be more of a poorly differentiated thyroid cancer? Obviously, lymphoma is the other important differential diagnosis. And once in a while, you'll actually get rapid enlargement of goiter from autoimmune Hashimoto's disease. But the history here is one of anaplastic thyroid cancer or lymphoma from the sounds of it.
Dr. Lubitz, for the endocrinologist in the crowd, when we're dealing with these rapidly progressive things, what kind of questions do I need to ask about airway or breathing or voice that would be, I don't send you an email and ask you about this case. It needs to be more urgent. What are the tips you could give us, Carrie?
Well, I just saw the CAT scan, so you saw my face when I saw the CAT scan. Obviously the first thing is obviously airway, and secondarily whether or not the patient has any voice changes, and obviously doing a laryngeal exam to see whether or not the vocal folds are still mobile.
Very good. All right, Dana, so take us through the imaging and show us what you got.
Okay, great. Well, so this is the contrast enhanced CT. Where you can see that the trachea has been pushed way over by this right side neck mass, and I don't have a little arrow, do I? I guess I don't. Anyway, so you can see kind of in the back that it's really right near the esophagus. You can't even, it's kind of hard to see any sort of soft tissue in between the internal jugular vein and the mass. And actually, if you keep going, next slide, please. There's actually a tumor thrombus in the internal jugular vein. And so there's this big mass that's kind of going through the middle thyroid vein into the internal jugular vein. And again, on this slide, and the upper right-hand slide, you can see that it's sort of going into the cricothyroid membrane. It doesn't seem to be in the tracheal lumen or the larynx quite yet, but it's gone through that membrane. And this is it's poorly limited. It's kind of going all over the place. The carotid is back in there somewhere too. So this is something that doesn't look very amenable to surgery right away. Next slide. Let me get the next slide up. And then,
Mike and Dana, can I interrupt for just one sec?
Yes, great.
So I'm so glad to see a contrast enhanced CT scan. And, this is one case where you suspect a thyroid primary, where nobody should ever yell at you if you get a contrast enhanced CT scan. In fact, that's exactly what you don't want to waste time getting a non-con CT for a patient like this.
Yeah, thank you, Lori. That's an excellent remark. And I think people do need to, all of our colleagues do need to say it's okay if you use iodine for thyroid. It's okay. It's okay.
So I would actually add to that and be more firm about that. It's not just okay, it's essential, because you need to understand what these surgical planes might be. And without this contrast, you can't get that information from a CT scan. So it's a fundamentally important imaging modality for large and potentially invasive tumors.
Excellent. Thank you. So I'll go quickly through these slides. Gabby, you can see there are mediastinal nodes here that are actually pretty big. Next slide, please. And some lung metastases. Next slide. Yeah, the kind of small lung metastases, and that was it. Next slide. You've got the FDG PET here, and you can actually see the thrombus in the internal jugular vein that's, excuse me, that's taking up that 18 FDG. Can you get the next slide, please? And then the METs in the mediastinum again, and lung metastases. Okay, next slide.
Hold there for me.
Sorry.
Flip back
Yeah,
one. Yep, flip back one. So we're trying to trick you down this pathway of anaplastic, and this is probably not going to be anaplastic. It'll be poorly differentiated or something. David, help me. The role of the PET scan, up front for these kind of imaging, and does this help me understand anaplastic versus poorly differentiated? Talk a little about FDG PET in this setting, David.
Yeah, certainly. So look, FDG PET, there's several indications in thyroid cancer. Certainly staging of more aggressive forms of thyroid cancer, so including either poorly differentiated, tall cell or particularly Hartl cell, is characteristically very intensely FDG avid. So with these images, without looking on a workstation, just based on the color scale, it looks very avid. So certainly SUV.
Endocrine surgery at Massachusetts.
And with Hartl cell carcinoma in particular, because of that oncocytic phenotype and a mitochondrial defect in oxidative phosphorylation, which is a characteristic feature of that, you can get very, very intensely avid disease, SUV max above 50. So it's certainly helpful to stage, and we can characterize, the extent of the disease very accurately. It also provides very important prognostic information. I mean, we can gather that already from other clinical cues, but certainly with that degree of the intensity of avidity, it also confirms it's more likely to be an aggressive malignancy.
Mm-hmm. Any role for radioactive iodine here? Because it sounds like Dana doesn't feel really anxious to go do a surgery here. Any conceivable role for radioactive iodine here?
At this point, pre-surgically?
Yeah, because she's going to bail out of surgery. I've got this French feeling from we may not want to do surgery. I'm pretty subtle that way. Yeah. Yeah,
look, I mean, the big concern is obviously there's still a remnant thyroid there that hasn't been removed. So we would avoid, radioactive iodine, pre-surgery. For that reason, it all gets sucked up in that avid, in that normal thyroid tissue. After thyroidectomy, that degree of FDG avidity, it really suggests it's much less likely to be radioactive iodine avid, and more likely to be a non-retainer of iodine. Yeah.
All right, Dr. Hartl,
if I can just add a comment, Mike. I think one of the things that I've long said about radioactive iodine, it really is most helpful in people who don't need it. The well-differentiated cancers that are intensely avid, but often you can manage those without the radioactive iodine, and it's pretty much useless in the people who really need the benefit of the treatment. And this is one of these individuals where the probability of response to therapy is exceptionally low. And if you go ahead with radioactive iodine, you're going to be treating this patient for weeks while his cancer progresses.
Yeah, and swelling things with TSH stimulation. So I'm with you. All right, Dana, take us to the chase. So what are we dealing with?
Next slide. Okay, so we got US guided microbiopsy up front. We didn't do FNA. Again, because we're thinking anaplastic or lymphoma or some other, something strange like a metastases from another primary, but we've got the FDG PET anyway. So we're on anaplastic or lymphoma, and it was actually differentiated thyroid cancer within an aggressive form, the insular form. And I'm so sorry, Dr. Ghossein, I don't have the initial slides, but you'll have some slides later. And we did do upfront NGS because we were thinking of going toward some targeted therapy or systemic therapy anyway for him. So we got that information. He had NRAS mutation, not BRAF, unfortunately. And we do a Ki-67 on these pretty regular, probably all of our tumors. We do a Ki-67 just to kind of get an idea maybe of the aggressiveness, even though it's not in the guidelines.
Let me hold there for a second. Let me go to Ronnie. Yeah. Ronnie, say a word or two about Int'l, and then let me come to Lori and talk about upfront fancy sequencing, next generation sequencing in these folks. Ronnie, Int'l?
Sure. Okay, so insular thyroid carcinoma is a term used when the late Dr. Roussy described the first subset of poorly differentiated thyroid carcinoma. These are tumors that are at the histologic and prognostic level intermediate between well-differentiated, the very indolent well-differentiated, and the catastrophic anaplastic carcinoma. Insular means
we generally do
solid nest of cells recapitulating fetal thyroid. What is really important here that there are thyroglobulin positive, and that does not exist in anaplastic, almost extremely rare in anaplastic thyroid carcinoma. And insular carcinoma, if I want to make it a little bit simple, it's like a high-grade follicular carcinoma, like in the 1960s and 70s, it would have been called follicular carcinoma. So I'm not at all surprised that it has a RAS mutation. And in a paper that's going to be accepted soon, we actually show that this type of poorly differentiated thyroid carcinoma, believe it or not, they pick up radioactive iodine. But whether it works is another story.
Right. Lori? Lori, thoughts about upfront doing, that Dana did next generation sequencing. We haven't even done surgery. We haven't done anything yet. I mean, this is really pushing molecular diagnostics right to the front. Is that where we are now? Yay.
That's what you want to do. Yay.
How's it going to help you, Lori?
Well, so first of all, the BRAF status is critical. You know, we're going into this guy's room thinking that this is an anaplastic thyroid cancer and that he's going to be in trouble in days, not months. And so there's the activity of BRAF-directed therapy in anaplastic thyroid cancer is really surprisingly phenomenal. And so you want to know that, and you can answer that question quickly with BRAF IHC. You know, that's one thing that I think that we would plan to have teed up. And then the NGS testing is also important. The patient has locally threatening disease, but also distant metastatic disease, and it's unresectable. So a systemic therapy that's not radioactive iodine is going to be needed in this patient. Since we don't yet know the histologic diagnosis, there's a very good chance that there's a BRAF V600E mutation. There's a chance, of course, that there's an NRAS or HRAS mutation, but also it's possible that they're activating fusions, RET, NTRK, and ALK. And so you want to have testing cooking as quickly as possible to identify all of those actionable alterations.
Carrie and then Bryan. Carrie, for me, what makes something not resectable in terms of that? And then Bryan, if we're not going to be resectable, is there anything we can do before surgery, neoadjuvant, to kind of move us in the right direction to make surgery better? So Carrie, what's unresectable?
The one thing that just popped up that Dana mentioned was that the extent was above the cricoid. I think once you get up into the larynx, it makes the potential of doing a tracheal resection and the comorbidity of that next to impossible. So in terms of that, I mean, you can take the IJ, you know, clearly that we used to do that all the time with modified radical neck dissection. So you can take that IJ, do a lateral neck dissection, lose that nerve on that side, which is clearly involved, right? You know, and then you know, before this case, I would definitely do a bronch, or when you're looking at if you're doing a fiber optic, make sure there's no tracheal invasion. That's you know, you need to be prepared for the case, right? So if you're going to do a trach R&R, to have that, you know, be ready to do that, and also potentially look at the esophagus as well and see if there's any invasion into the esophagus. You can take the wall, a little bit of the wall, and put a patch on it. But really, the thing that Dana mentioned was that the extent how high it went up into the laryngeal area above the cricoid.
So
Mike,
Bryan,
can I jump for 1 second regarding one little thing? The Ki-67, it's true that in you know, it correlates with the grade in thyroid carcinoma, like in anaplastic there's much more than in PTC, but here in disagreement with my good friends from Gustave Roussy, just I'm saying that for especially North American pathologists, I'm not a big fan of Ki-67 because often you see it low, and even in anaplastic it's not that high actually, because we did a large anaplastic study, sometimes you find 20%. So I wouldn't, it's fine to do it, but really I will give it very, very little importance. I don't know why in follicular cell-derived thyroid carcinoma is different from neuroendocrine, for medullary carcinoma. Ki-67 has very weak correlation. Counting mitosis and detecting tumor necrosis is more important. I just don't want people to think, oh, it's Ki-67 high, it's bad, or low, it's good. Actually, that's a very good example here. I don't know why it doesn't work well in follicular cell-derived thyroid carcinoma.
Gotcha. So Bryan, let's assume this is not going to be surgically resectable for right now. We're probably headed toward a systemic therapy. Any expectation that systemic therapy is going to be neoadjuvant or shrink and make surgery? Where are you sort of thinking in that space right now?
So certainly there are some clinical trials going on. I know the folks in Boston, Lori probably knows more than I do about the details of this, but there's a clinical trial of neoadjuvant lenvatinib to try to shrink these tumors and make them surgically resectable. I've not seen preliminary data from that study at this point, but certainly that's one valid strategy to consider sending this patient for a clinical trial of some sort. To my knowledge, there are no current clinical trials that target NRAS, but obviously we all need RAS inhibitors at some point. The alternative approach here, of course, is to manage this patient with external beam radiation therapy. And I think that we've got to protect this guy's airway, protect the swallowing mechanism as best we can, and get this tumor under some semblance of control in the neck. And so typically we would be sending this patient under standard of care for radiation therapy to try and manage this disease locally in the neck prior to initiation of systemic therapy.
Okay, Dana, do this for me. Take me through his systemic therapy stuff, and then we'll stop right before we think about surgery and get Lori's comments about where we are at that point. So take me forward in the
Okay,
case.
great. Well, so we started lenvatinib in November, and it was actually very well tolerated. He had just some low-grade mucositis and hand-foot syndrome. He was a little bit tired. And we did put him on heparin because of the thrombosis in the jugular vein. That's just what we do without any really high-level evidence. And then 2 months later, we did a new workup, new CT, and there was actually a response, 35% shrinkage of this tumor according to the RECIST 1.1. Next slide. And I apologize, it's actually, this is baseline versus January and actually 2 months of lenvatinib. And you can see this where the actual, and one of the things for me was that the carotid artery was like gone. I didn't know where it was. It was sort of englobed in this, encased in this tumor. And that is also one of the things I look at when I look at resectability is the carotid axis. And the carotid sort of reappeared, and it looks like it's a little bit further from the esophagus now, and it's shrunk pretty nicely. Next slide, please. And even the mediastinal nodes have gone down. They're almost like half the size. Again, next slide, please. And even the lung mets responded. Next slide. I think okay. So we kept going with the lenvatinib because it was so well tolerated. And he had reached the nadir actually that 2 months, and then it stayed stable after, and after 17 months of lenvatinib, it was still stable. And then all of a sudden he had this heart attack. And Lori, you'll tell us if you think that, if you're convinced that it's because of lenvatinib or not. He did have some vascular issues beforehand, but we sort of were a little bit worried about that. Anyway, he had 3 stents. And then he was still on the heparin plus aspirin. They didn't put him on any antiplatelet medication, but we did stop the lenvatinib. And then 2 months from his stents, he was doing okay, and his tumor was still stable. So I think that's where, next slide, I think we have another slide. Yeah, stable tumor. And it's sort of has gone, seems like it's pulled away from the larynx as well. You can see on the left-hand side, it's sort of in between in between the thyroid cartilage and the cricoid cartilage. And here it seems to have cleared out a little bit. So he's still stable. Next slide. And you can see this thrombus here, and it's still there. Next slide. And this is just the ultrasound of the tumor thrombus in the internal jugular vein. Next slide, please. That thrombus. And I think that's it. Yeah, we can go back one or whatever.
Gabby, go back to 21 for me. Carrie, to you. Time to do surgery. This is a fairly dramatic response. You good to go now?
I give it a shot. No, I think that was an incredible response. I was trying to see, the esophagus looked like there was, the nice thing you can see on the CT is that there's a plane, a very clear sort of straight line. You don't see any bumps into the lumen of the trachea or the esophagus. So, and like Dr. Hartl was saying, that it really seemed to pull away from everything. And great point about the carotid. So I would give it a shot, but I would let the patient know that, they're likely, I assume, we didn't talk about it, the vocal fold. I assume it was out on this side.
No, it worked. It still worked. Yeah, sorry.
Oh.
The vocal fold was still mobile.
Yeah, so I mean, I think still, even though it still can be encased with the nerve, with tumor, even though it's functional, as most of us know. But yeah, I would go in with the approach of taking out the right thyroid. I use a nerve monitor to see whether or not that nerve is functioning through that dissection, and depending on whether or not it's encased or not, take the nerve or not. I would do a central lymph node dissection as well as a modified radical on that side, including taking out that. So it wouldn't be modified. It would be. I forgot which of the radicals. You'll have to tell me. The otolaryngologist will remind me, but I would definitely take that IJ with the tumor thrombus in it and clear out all the lymph nodes. Depending on the function of the nerve on that side, and that there's no evidence of any tumor on the contralateral side, we might have to go in there, and I would also prep the patient that they potentially could need a trach, and so just be prepared.
Okay, we're going to need to move along a bit. Lori, give me some comments here, because I know you've thought a lot about this neoadjuvant setting. What are the right patients? What are the indication for surgery? Where are we with that right now, Lori?
Yeah, so, well, this is a great advertisement for Greg Randolph's neoadjuvant trial. So I'll pass on his thank you to Dana and Bryan for giving this free plug for Greg's trial. But we are, so we are looking at neoadjuvant lenvatinib in patients who present with this kind of bulky disease, where if you tried to resect it, you would certainly be looking at an R2 resection, and the primary endpoint is R0 or R1 resections. And the trial has just recently gotten underway, so we're not close to having preliminary data for presentation yet, unfortunately. But the reason that we did the study is because you can see incredible responses with lenvatinib. Usually when you see responses with lenvatinib, which is in most patients with advanced thyroid cancer like this, you see a very dramatic drop off in the tumor volume in just the first 2 months of therapy. So the idea of making a lot of gains in the first 2 to 4 months so that you can get a patient to the OR is actually this is a very realistic goal to be striving for in a case like this. So hopefully we will have data from a study at some point to show that this kind of approach really can work in a research point of view. There's always a lot. So 2 other things about lenvatinib. Poorly differentiated thyroid cancer patients were enrolled in the SELECT trial and responded, as well as other more well-differentiated thyroid cancers. So poorly differentiated thyroid cancer is not a reason to withhold lenvatinib. And then also the patient has metastatic disease, but I agree that the idea of thinking about surgery for local control is very reasonable. If you prevent the patient from dying of suffocation from his neck disease, you've done the patient a lot of good, even if ultimately you might not cure his disease forever.
That's
and Mike,
beautiful.
if I can just weigh in on just one minor point, and that is the issue of clinical trials. Traditionally in thyroid cancer, it was said that you can't do clinical trials in thyroid cancer because it's too rare, patients live too long, you can't study folks for that long. It's completely untrue and unfounded. And Lori, to her immense credit, has proven that to us many times over. So for a patient like this, if there's any way to get access to a clinical trial, that should be our standard of care.
Dana, we need to finish this case in about 5 minutes. So
Okay.
give me the operative findings. Let's let Ronnie look at the slides for us.
Okay, yeah. So I did what you said, Carrie. It was a radical modified loss of signal, but the nerve was actually spared, and he did very well postoperatively. And we got to go to the slides. Next slide, please, Gabby. There we go.
Okay.
So I think that's for you, Dr. Ghossein.
Yeah. So here, what I see, it seems that there is tumor in a vessel outside the thyroid. And this is a very low power, so I don't see the architecture very well, but it looks like solid.
We have more
Next one.
slides. Go ahead.
There we go.
Okay. Okay. Yeah. You next one. All right. So here, okay. So this is really now you see that it doesn't seem that it's still not very high power, but it doesn't seem that I'm making follicles. So that's in a sense, I would think that this is a solid nested pattern. One more.
I think we have a higher. Isn't there a higher one? I think.
It's okay. Here. All right. Okay. Okay, so this becomes interesting. So here, basically, that's what you see. This is a nested growth pattern, and you can see sometimes follicular lumen in between, but the nested growth pattern. Now, there's one thing here that I have to tell you. In North America, we will actually, most pathologists will think that this tumor has the nuclear features of papillary carcinoma. And I know in Europe they don't. I also see a mitosis in the lower half of the field. So actually, personally here, I would agree with the Gustave Roussy pathologic. I think it's a poorly differentiated thyroid carcinoma, depending on the amount of mitosis she saw and necrosis. The fact that it have nuclear feature doesn't change. It doesn't mean it's a papillary carcinoma, because it's an NRAS mutated tumors. So I agree with, I think it is a poorly differentiated thyroid carcinoma. I will say it has a papillary nuclear phenotype, but it's not that important. It's going to behave like a poorly differentiated thyroid carcinoma. Let's see, next one, or that's it. Yeah, here we clearly see the mitosis, that dark spot inside, so very, very convincing. And then more, and that's enough.
Oh yeah, that was the operating thing.
Yeah.
That's okay. That was the mass that was resected en bloc with the internal jugular vein.
Wow. But
Next
definitely
slide.
there is no anaplastic. Absolutely no, because there's no nuclear pleomorphism at all. Yeah.
Okay, next slide.
And then the question was, well, it was iodine first or external beam radiation therapy first. And so he's actually right now doing, I think he just finished his radiation therapy. So we did the radiation therapy first, and then we'll probably, I don't know if we even are going to give radioactive iodine. It's not even worth it, but maybe just to say that he's refractory and then go on and be able to put him into a clinical trial afterwards if his heart is okay.
On the next tumor board, we'll talk about this case. Next case. We could spend the whole time on that one. This one,
Yeah,
this
sorry.
one's a quick one. No, that's great.
Quick
This
one?
is a quick one, but
Yeah.
it brings up a really important point that comes up every once in a while. All right, Dana, let's do this one.
Okay, next slide. This is an 18-year-old young guy who palpated a neck node by himself, and it was a 15 millimeter right lymph node in level 3. It had cystic areas. He had some micronodules in his thyroid that weren't very suspicious, and the FNA with thyroglobulin in the washout fluid confirmed papillary thyroid cancer. See some of these, and this is just to go through some of the ultrasound. Should we skip that?
Yep, skip that.
Go ahead. Yes, so microcalcification, cystic, everything. So he had total thyroidectomy, bilateral central neck dissection, and a selective therapeutic lateral neck dissection, levels 3 and 4. And final pathology had a microcarcinoma on the right-hand side. He also had a microcarcinoma on the left-hand side. He had 4 metastatic nodes in the right neck. The largest one was that 15 millimeter node. And then he had a lymph node in each central neck, one each, that were micrometastases. Next slide. So we gave him, I don't know if you want to talk about this, he was intermediate risk for recurrence.
Go back one for me. Dr. McIver, once upon a time, somebody told me papillary microcarcinomas were basically not even cancers. So what are we doing with a 6 millimeter? There's a 15 millimeter lymph node metastasis. Is this high risk? What's going on with this guy?
So this guy is a young person, and young people with papillary thyroid cancer often have florid nodal metastases, and occasionally, of course, distant metastases as well. And it can happen rarely from even papillary microcancer. So the guy presents with a partially cystic mass in the mid-neck. It's not uncommon for them to see an ENT, and the ENT will say, oh, it's going to be a branchial cleft cyst. The phrase we use around here is never a branchial cleft cyst, it's always happened. Thyroid cancer. And so again, although this is not a common presentation, it's certainly a well-recognized pattern with a metastatic papillary microcancer. The vast majority of papillary microcancers discovered incidentally do not present with the nodal metastases, but if you find a lump in the neck in a young man, the likelihood that that's going to be papillary thyroid cancer is relatively high, and it will often be a microcarcinoma.
David, the role of radioactive iodine, I mean, it changed in the 70s, and then by the 2000s, everybody was getting it. Now, not so many people are getting it. We're kind of in the middle. Down under, where are you guys with using, this guy had a good surgery, had an excellent surgeon. This is going to be adjuvant therapy if we give it. So where are you with radioactive iodine with these kind of guys?
Yeah, look, I mean, overall, we're becoming more discretionary in our use of radioactive iodine, I think, like elsewhere in the world. In this case, it's intermediate risk. There are several lateral nodes involved, up to 15 millimeters. So we would give radioactive iodine in this setting. And I mean, I've already seen the slide, what was given at Dana Center, but we'd give a similar dose of about, 4 gigabecquerels or about 100 millicuries. And that's our approach with recombinant human TSH.
And Dana, Gustave Roussy now, are we still 100 millicuries for everybody, or are we becoming more selective, or sort of where are you guys rolling now?
We just basically have two doses. We have the 100 millicuries for the ones that are kind of the higher part of the intermediate risk, and 30 millicuries for the lower part of the intermediate risk patients. So that's kind of what we're doing. We're kind of limiting it.
So we gave him 100 because he presented with the cystic lateral lymph node met. Okay, yeah. Let's go ahead.
Next slide. So okay, right, back up one. Yeah, thanks. He had a whole body scan of the remnant, and then there was this little uptake on the other side, on the left-hand side in the lateral neck. His stimulated thyroglobulin was at 5.3 with no antibodies. And so the case scenario number 1 is the real case. And then I brought up a case scenario 2 just to maybe discuss what would happen otherwise. So the first scenario is, the real scenario is that his neck ultrasound was like completely negative. And then the second case is, would it change something if we did find a macroscopic structural disease in his neck on ultrasound? So that was sort of the question I want to bring up. But the first one is, we've got 5.3 and nothing on ultrasound.
So David, help me here. Let's do case scenario number 1, that in fact you do give a dose radioactive iodine, the post-therapy lights up something, and structurally we can't find it. Is that real disease? Is it false positive? Is that just sensitive radioactive iodine? As a clinician, how should I think about that?
Yeah, look, I think it all depends on the appearance of the scan. And so, you know, if there is, it certainly looks hot. It looks like there is something that's very focal. There's intense uptake there. It's in the expected location. The patient's got nodes on the right. We know that. There's central nodes. It's not unexpected to find a node on the left side. You'd look, and often when you do look, you might see a very small correlate node that wouldn't necessarily be seen on the ultrasound, you know, prospectively. And so it might be sort of a 3 millimeter node there. And so I think, you know, we're thinking I would be interpreting that as quite likely to be disease in this setting, and just looking at those images. And so in terms of the way to manage that, though, you know, in this point, I think it would be a matter of observation. If it's something so small that it hasn't been seen on ultrasound, there's no target surgically. So then I think at this period, it's a matter of observation, see what happens with the thyroglobulin over time, you know, repeat neck ultrasound, etc. And then it becomes clearer after that whether it's, you know, excellent response or not, and whether further therapy is required. Considering potentially, you know, a diagnostic scan, and, you know, we use I124 PET, not in all cases, but selectively, you know, at our institution. And so there's other options down the track if that was required, but probably just observation and not much else.
Yeah, Dr. McIver, as the team captain of our team radioactive iodine minimalist, can I get you to admit that radioactive iodine actually helped this person?
Well, I'm not sure that we've helped the person yet. The guy has a residual node that we've picked up. What remains to be seen is whether that node will progress and become anatomically detectable, whether the thyroglobulin will rise, or whether it will fall and this disease will become stable or even shrink over time. Radioactive iodine is not useless. I think that the argument I've made over the years, it should be targeted for people who can benefit. This guy is right on the edge of where he might gain some benefit. Retrospective data do suggest that these intermediate risk individuals gain some small incremental advantage to being exposed to radioactive iodine. The embarrassment for all of us is that we've never proven that in a prospective clinical trial. And our failure to do that over my entire lifetime in this field is an embarrassment personally to me, and it should be embarrassing to all of us professionally.
But if radioactive iodine was ever going to work, it's probably going to be in a teenager with well-differentiated thyroid cancer, right?
Agreed.
Yeah, so this would be a setting. Carrie, let me take you to scenario number 2. We have to be a little careful here, because the surgeon was done by what we often refer to as an outside surgeon, right? You know, this never happens at Memorial, but the outside surgeon does a surgery, and when we do radioactive iodine, we find a 13 millimeter lymph node. Did this regrow in the last 6 weeks, or did we just miss it at surgery? So talk about that sort of conundrum that we see.
Well, if I remember correctly, the patient had a right-sided neck dissection, correct? So this is on the contralateral side. Yeah. Okay, just checking. But yes, clearly you need to do a full compartmental dissection, right? No cherry picking allowed. And generally with papillary, many endocrine surgeons and head and neck surgeons just selectively do levels 3 and 4. I do 2 through 4 for well differentiated thyroid cancer, and for medullaries, the full 2 through 5. So for this case, it's funny, Lori and I have a patient, and she knows who I'm thinking about right now, who we've been following with a small lymph node forever and a slowly climbing thyroglobulin, like literally over the course of 10 years. And you have a number of options, and the one option is, and I think historically would be to clear out that entire side, that if there's one node over there, there's going to be microscopic disease elsewhere on that side. So if you are going to go to surgery, you're going to do the full extent of surgery on that side to clear it out, so that we're not doing this again in another 4 years. Secondarily, there's, I'd be interested to hear what Dr. Hartl says about what you're doing, and David, maybe in Australia, with ethanol ablation or RFA for these small nodes, and whether or not that's something that's coming down the pike as a potential treatment for these small nodes or recurrences. So maybe you guys can comment on that.
Dana, you want to talk about, we'll leave this case for a second, small lymph node metastasis, treating it with something other than surgery, usually in a previously operated neck most of the time,
Yeah. But
yeah.
this patient, I guess for something that's over 1 centimeter, we would say the radioactive iodine isn't going to get rid of it. He's young. We would go back in and do a neck dissection, like Carrie said, for him if it was macroscopic disease. But that's a tough question. We're not doing ethanol ablation or radiofrequency ablation for recurrent neck nodes at our institution right now. We don't have the the experience and that sort of thing. And the problem is, I find most of the time is that these nodes are like right next to the carotid artery. And if you've already had a neck dissection, what happens is you've taken out all the fat and all the fascia, and everything sort of collapses together. So even when you go back in surgically, it's really tough because everything is so close together. And these nodes are often like right next to the jugular or the carotid. So we have a hard time finding, we've got colleagues who do it, we have a hard time finding good candidates. I don't know, I'll let somebody else.
I think we're the same way. David, let me take you back to this case. In cases like this, if we find a 1 or 1.3 similarly treated and it's REI avid, we don't go back and operate. We watch, and most of them stay stable. They don't disappear. They just hang there for years and for 20 years. What's your expectation on one like this, that the radioactive iodine would work? And if it worked, what does that mean? Does it go away or does it stay stable? TGs? What would you tell this young man's family?
Look, I would say that, so if we're assuming it's a 13 millimeter lymph node, is that's the case?
15 millimeter, 13, 1-3.
Yeah. Okay. So I think we're saying that, look, there has been uptake there. We're not necessarily expecting that it will completely disappear. There is a chance that it could, depending on the amount of uptake that we've seen. But it's more likely that we might see either stability of that over time or perhaps some regression. Is something we might hope for, but it can be monitored on an ultrasound.
Bryan, 1 minute, REI avid positive lymph node that you found on the post-therapy scan. What's your approach?
Watch it. You've given him active treatment. You also have him on the appropriate chemotherapy for thyroid cancer, which is thyroid hormone, presumably keeping that TSH towards or at the low end of the normal range. So he's got 2 therapies on board. His prognosis is excellent for longevity. He has some significant risk for future development of other nodal metastases. So I would keep my powder dry, monitor this thing over time, and determine whether the radioactive iodine did what it was intended to do.
David?
Mike, I just had one other comment. Yeah, I totally agree with that. I think previously, and at some centers, people will follow up and give more radioactive iodine, etc. And I think it's a trap in this case because it's neck. It's only got disease confined to the neck. It's very good prognosis, and there is risk if someone gives repeated doses of radioactive iodine to someone at this age.
Right.
So,
we would completely agree. This is a surgical disease if it needs to be treated, right? The question is it detectable or actionable? And that'll vary based on patients and center and location. If this is sitting right beside a nerve, that may make us do it sooner or later. So good. It's nice to have the options. Okay, Dana, let's do the last one because the last one is really interesting as well.
Okay, can you skip to the last one, Gabby? Thanks. Okay, these are actually real cases. These are true stories, you guys. So this is a microcarcinoma. Go ahead, Gabby, please. Great. So it's a 30-year-old female. She has no notable medical history except gestational diabetes, and she was followed up at initially in an outside institution, and she'd had a neck ultrasound, and they found a incidentaloma, as we call it, a single thyroid nodule in the left lobe, 8.2 millimeters. It was classed, TR5 for Americans, euthyroids, 5 for us Europeans. And she had no problem with thyroiditis or anything. Next slide. And this is what it looks like, this dark thing in the back. Next slide. Let's see, that's, that's what it is. Very hypoechogenous, poorly limited, and it goes right up against the posterior capsule of the thyroid lobe here. Next slide. Again, right against the capsule.
Okay,
next slide. Oh, you want
hold on a
to do it?
second. Gabby, take me back to 38. Carrie, we don't know what this is yet, but obviously, if it was a thyroid cancer, anything about this location that rings bells to you for the endocrinologists that don't have that panic look when this comes up, can you tell us why we should worry a little here?
Yeah, this is an ugly looking tumor, even though it's small. So not all microcarcinomas are benign, as they say. So obviously this is right where the tracheoesophageal groove, that's right where that recurrent laryngeal nerve is. Also the esophagus is sitting right there, normally always hanging over to the left there. And the irregular borders really are the shape of the, the tall versus wide, and the irregular borders really are concerning. In addition to the tracheal, I can't see it on this ultrasound very well, but it looked like on the sagittals that it looked like there was a clear plane between the trachea and the tumor right now. But this would definitely be a surgical case for me, 100%, because this is not going anywhere good if you don't get it out now.
Right. So even though sometimes small lesions in bad locations still need to be treated, right? So this alone, from even that one image, for the ones of us that do a bunch, raises flags. Okay, so go ahead, Dana. So what happened?
Next slide.
41. There we go.
Okay, so she had, this is all at another institution, actually in another country. She had FNA and it was benign. Okay, so.
All right, Dr. McIver. So now it's not just an outside institution, it's another country. So
it is.
In Europe, we criticize
was.
other countries, which is good. Brian, Carrie was really worried about this ultrasound, but now I can chill because it's a benign biopsy, right?
Yeah, no. You should never throw out the prior data just because you've got some new data in front of you. You've got to integrate it all. The clinical assessment is important, the ultrasound is important, and the FNA cytology is important. But if the ultrasound looks that suspicious, then I'm not trusting this benign FNA. It's a small lesion. We don't know who actually performed the FNA procedure. It's certainly conceivable they missed the lesion altogether. And false negative FNA is a distinct possibility. It's uncommon in good hands, but it's certainly possible. Rates are 5% or so of false negatives. In reality, it's probably a bit lower than that, but nonetheless, it can happen. And this is a false negative until proven otherwise.
And so if this came to you from the outside, you'd just go ahead and do a repeat biopsy now?
Absolutely.
Yeah. Okay, Dana, where'd we go?
Hey, can I ask a question?
Yeah.
Yes.
So now,
or something. David, help me.
Would you be doing an FNA with molecular diagnostics or an extra pass just in case you want to send it off?
We always collect molecular markers on every FNA we do, so that if we do get indeterminate cytology, we have the option to send that test. We don't reflex the test necessarily, but we do always collect it as our standard operating procedure. And actually, we do this as a washout of all of the needles that we're using otherwise for the biopsy. It's not an extra pass.
Okay, Dana, go ahead.
Excellent. Okay. Yeah, next slide, please. So she was actually, they kept following her up. They were very, on the ball about following up this benign
anaplastic versus poorly differentiated.
So, but it remained pretty stable over several years, over 3 years. It went from 8.2 to 9, which is not really significant. Next slide. And then that's when I saw the patient in the clinic, because she was sent to me for dysphonia and she had left vocal fold immobility on fiber optic laryngoscopy. Next slide. So I did the whole workup for laryngeal mobility, right? The CT, the contrast enhanced neck and chest CT, just to see what's going on here. And the only thing that we found was this small thyroid nodule in the back of the left thyroid, of the left lobe. Next slide. And so we didn't like it, and we said that's not benign. So we did a cytology on it, and it wasn't. But still, you can see on this ultrasound, it still looks like there's kind of a capsule, a posterior capsule, keeping it away from the esophagus, and it was pretty far away from the trachea as well. So we were pretty convinced that this was just idiopathic laryngeal paralysis, and she had this incidentaloma. But because of the location, we said, well, this is probably better to remove it, as Carrie said. Next slide. And oh, rats. Ah, there you go. And this is what I found. Her nerve did not respond at all with nerve stimulation. It was completely, no nerve, none of the electricity was going through the nerve, and the nerve was completely surrounded by this tumor that actually invaded the esophagus superficially. And so I actually resected the nerve because it was non-functional, and did total thyroidectomy and a prophylactic central neck dissection because this is kind of an invasive tumor. And what's interesting is that her voice was the same before and after. I said, I didn't expect that her voice would change because I didn't expect her nerve to be invaded, but in the end it was the same as before, which is good. Next slide. So that's what happened. We had to just do a shaving of the esophagus off of that. Next slide. I think we have some pathology for, okay, this is pathology was a classic papillary, but with a 25% tall cell component. There was vascular invasion. The nerve was invaded, and we'll have some slides of that. And the resection was considered R1 because it was a shaving in the esophagus. She had 2 other microcarcinoma and 2 micrometastases. So it was a T4A and 1A. Next slide. Oh,
pause there for a minute, Dana, and then we'll come to Ronnie in a second. Dana, just talk a little about, we've definitely seen papillary microcarcinomas invade the nerve, and they often have that pattern Carrie picked up. There wasn't a discrete boundary, right? They have that sort of infiltrative around the edges. It's kind of hard to know. But to have one of these invading the esophagus, when's the last time we scraped a papillary microcarcinoma off the esophagus or the trachea, right?
That happens. I actually had another one, like maybe it's just me. I just collect them. But it does, it can happen. It can happen. And it's these tall cells. It's these, not for me anyway.
It's not the classic. Carrie, you see that? We see these small things do that?
Something strange like
seen a microcarcinoma invade the esophagus, but it doesn't surprise me. I've gotten into a case where with larger tumors and also tall cell, actually, where you have to take off the muscular, the external muscular layer of the esophagus, and it's scary and not fun when you get in there if you weren't planning on it. I actually, during those cases, I had another surgeon come in and actually scope the patient, make sure that there was no invasion of the inner layer. And so, yeah, that's scary. One question I have for everyone is, would Dr. Hartl, if the nerve is out, would everyone take out the other half? Is the question, if there are no nodules on the other half.
Dana?
Yeah, well, this is an aggressive tumor for me, a tumor that invades the nerve and the esophagus. This is a Denise papillary. And a lot of these don't even show radioactive iodine uptake when they have these bad histologies. So for me, this was a bad tumor, and she would need radioactive iodine, or we'd want to be following her up. And so I did do the other side.
Yep. So Ronnie,
excuse me. Well, she also had pre-op paralysis, so she had been prepped. I had said, if we have to take out, you might have to have, tracheotomy. I always say, we might have to do something. So.
Yeah, careful. Ronnie, talk a little bit about tall cell. There's something here about 25%. What's the behavior of these tall cells? You've studied these a lot. Tell us a little bit about those.
Yeah, so very briefly, Toll cells.
The BRAF status is critical
here, and this has been adopted in the WHO when it crosses the 30% threshold, which of course is a subjective. But more importantly, what does it mean to have a Toll cell? Now, as a group, they do definitely, this has been proven over 30 years, much worse than, they do worse than classical papillary carcinoma. But I'm not sure stage for stage. I mean, of course, it's very important for people to realize that in incidental 8mm Toll cell in the middle of the thyroid, I wouldn't worry at all about it. And we did some data, and we couldn't really see on multivariate analysis, Toll cell did not survive stage. I think this is a really important message. Now, it happens here that was located in a bad area, and so I'm not sure it behaved badly because of the Toll cell. That we don't have proof of that.
Or the location. Show the next slide. I think we got invasion of a couple nerves in the nerve here, Ronnie.
Yeah, so I really agree totally that there is papillary carcinoma encasing the nerve. It's not, for those who are head and neck surgeons, it's not the perineural invasion you see in adenocystic carcinoma. It's not really, but yeah, definitely there is invasion of the nerve. There's another one, I think. The nerve is, and here also you see really more the term is encasing. I mean, it's not really inside the nerve, but it's surrounding it. Yeah. And I have to tell you, this is rare in papillary thyroid carcinoma. There's a paper in Australia that said 35%. I don't think Dr. Pattison is on it, but really I don't believe it, sorry. But this is quite rare, invasion of nerve. I mean, even I'm saying very, very small nerve fibers, like 0.2mm nerve fibers. Yeah.
Bryan, help me risk stratify this patient, because on one hand, we're about to write in our note, this is a papillary microcarcinoma invading a nerve in the esophagus. She's still a stage 1. What do you tell the family about her? I mean, this was a surprise. This was Dana has to go when she wakes up and say, this was more than we thought it might be. So how are you thinking about her case now?
So I think the most important message is that size matters, but it's not the only thing that matters. This was posteriorly located in the thyroid. Obviously, it was a missed cancer for several years. It grew and progressed very, very slowly, as we would expect a papillary thyroid cancer to do. But because of its location, it now had the chance to get its roots outside of the thyroid gland, encase that nerve, begin to invade the esophagus. So small, yes, but nonetheless, cancer for her locally. Now, realistically, the likelihood of distant metastatic spread is still very low. The prognosis for this patient really remains excellent for long-term survival, but she does have some significant risk for recurrent disease because we achieved an R1 resection, which means there's likely cancer cells left behind there. And as I think was pointed out by Dana, the ability to treat this with radioactive iodine is at least somewhat questionable. So this is a patient who's going to need careful follow-up with thyroglobulin, with ultrasound, but also with cross-sectional imaging, because in the soft tissues in the peritracheal area, you can't necessarily see the recurrence early with the ultrasound scan. So we would be using CT scans for that follow-up as well. So the picture I'd paint for the patient and the family is, you know, again, we're cautiously optimistic about long-term outcome, but we're going to watch this very carefully indeed. We're going to do what Ronald Reagan said about the Russians. We're going to trust, but verify.
Lori, we got about 1 minute left. Let me ask you, these patients all come to ask me and say, am I going to need systemic therapy? Do I need something now or in the future? You get to see all the people when they get to that point. Do any of them start like this, or is this just not a pattern that you expect to see in your clinic down the road?
Well, every patient that I see ends up having bad disease. Yeah, but you know, I think that Bryan is most likely correct that this patient probably does not have metastatic disease. But I've seen patients with metastatic disease who only have a microcarcinoma. So I wouldn't, I like trust and but verify for sure. The other thing that I would like to say is we get patients like this referred to us for the question of external beam radiation. And I think 20 years ago in Boston, a patient like this would very well get radiation to prevent them from recurring in these bad places. These days, we're really avoiding radiation unless patients do progress and have unresectable disease, locally advanced disease. then we'd consider it. But we just do not want to convict the patient to have to live with the consequences of radiation for the rest of her life.
Yeah, and in this patient, she got 100 millicuries radioactive iodine, and follow-up 4 years later, still disease-free, right, Dana?
She had an excellent response right away, and she's still, 4 years out, she's doing quite well. I mean, she's still an excellent response. So we haven't done cross-sectional imaging yet.
Okay, cool. All right, we can take the slides down. We are right at 9 o'clock. Thank you very much for our panelists. You guys did a great job. And I guess we agreed with what Dana did. So you get an A+ too for the care. So from at least this board. So we'll award your PhD. Thanks so much for participating. Have a great day, everybody. Thanks, Sal. Bye-bye.
Thanks.
Thank you, everyone.
Bye. Bye.